Hi, I am Dr. Debbie Saslow with the American Cancer Society, and I'm so happy to be invited to be here with you today to talk about HPV vaccination. So I'm just going to briefly do a little bit of level setting to make sure we're all on the same page. HPV stands for human papillomavirus. There are many types. This is an extremely common virus. And about 13 or 14 of the many types of HPV can cause cancer. And that's why we're here talking about this today. So everybody is at risk for the human papillomavirus. There are 325 million or so people in the US, and on any given day, about 80 million of us have an HPV infection. The lifetime risk of getting HPV is over 80%. That makes HPV a very important virus to discuss and to prevent. So, in addition to being a very common virus, why are we talking about human papillomavirus? HPV causes 6 different types of cancer: cervical, vaginal, vulvar, anal, penile, and throat. We have a vaccine that prevents the types of HPV that cause these 6 types of cancer, and we need to vaccinate more adolescents and screen more adults against these cancers in order to prevent them. We know that success is achievable. We know that we can vaccinate many more adolescents than we are currently vaccinating because we are doing this with other vaccines given at the same exact age. So here are the cancers, as I mentioned, that HPV causes. There are over 36,000 cases of HPV cancers diagnosed in the US every year. In women, the most common type is cervical cancer, but about half of the women diagnosed with HPV cancers each year are diagnosed with a cancer other than cervical cancer. And then in men, by far, the most common HPV cancer is cancer of the oropharynx or throat. Now, it is true that we can screen for cervical cancer. However, we cannot screen for any of the other 5 types of HPV cancers. And in addition, for cervical cancer, what happens is when we screen women, we often detect precancers. And so that's great. We remove those precancerous lesions, and the cancer is, in most cases, prevented. However, these lesions are extremely common, particularly among those who have not been vaccinated. And what happens is I call this the revolving door, and that's the reason for the graphic here. So a woman may come in, she may get her Pap and HPV test, she may have a positive result. It's not cancer, it's not precancer, but it's something, it's not quite normal. And so we ask the woman to come back in 6 months or a year. She comes back, she gets tested again, not quite normal. Let's come back again. She comes back a third time through that revolving door. Well, maybe this time she needs a biopsy or even a leap. And the story continues. It's not a one and done. This woman who has an abnormal, not quite normal screening result keeps coming back for years on end, keeps up with anxiety, with coming through the provider's office, with taking time off from work, with healthcare costs adding up. And so the HPV vaccine will prevent not just those life-threatening 36,000 cases of HPV cancer, or 90% of those that the vaccine will prevent. It will also prevent the vast majority of cervical precancers and other precancers for the other HPV cancers. So anal precancer, vulvar precancer, vaginal precancer. We know a lot about the genital cancers. A little bit less is known about cancers of the oropharynx. These are on the rise, and particularly those caused by HPV. So it used to be that the majority of oral cancers were caused by smoking and tobacco, and now in the US, that's no longer true. The majority are caused by HPV. And this is particularly important, as you saw a few minutes ago, in men. And so that's why it's important for boys to get vaccinated as well as girls. So with that foundation, let's switch gears a bit to HPV vaccines and preventing cancers by vaccinating adolescents against HPV. There are two very common questions that I get related to HPV vaccination. And the first is, does it work? Is this vaccine effective? And fortunately, we have many years of data that we have built up, and we continue to get more. The data started with proof of the very high, close to 100% effectiveness of the vaccine against HPV infections. Next, we had data on the prevention of genital warts, which this vaccine also prevents. Next, we had data on the prevention of abnormal Pap tests and HPV tests. And from there, because HPV takes a number of years to cause precancer and decades to cause cancer from the time of infection, it's been a gradual process to prove the effectiveness of the vaccine. So what this slide shows you is the effectiveness against those cervical precancers, those abnormal results that send women through that revolving door. And on the left, you can see that when in 2008, we first introduced the vaccine, actually in 2006, 2007, that blue bar shows a very high number of cervical precancerous lesions in young women. And in 2016, 8 years later, after a moderate percentage of girls in this country were vaccinated, that number decreased quite dramatically. But if you look across the right side, middle and right side of the slide, which is different increasing age groups, you'll see that those light blue and dark blue slides are pretty similar. And if anything, the light blue is higher, meaning that cervical lesions, high-grade precancers, have continued to increase over the years in women who were beyond the age where they could be vaccinated as the vaccine was introduced. So that's showing you the effectiveness of HPV vaccination in girls and young women against high-grade cervical lesions. Well, what about cancer? As I said, it takes longer to see the effectiveness of HPV vaccines against cancer. For cervical cancer, some young women do get cervical cancer. It's much more common in middle-aged and older women. And what this slide shows is that in Sweden, where the HPV vaccination rate is quite high, over the years, the vaccine has prevented almost all cervical cancers. And so what you see with the blue line is those women who were vaccinated on time, mostly at age 11, 12, but up to age 17. And the number of cancers in this group is close to zero. The orange line is those women unvaccinated. And you can see that that number of cervical cancer increases steadily and pretty dramatically with age. And then in blue, we have a small number of women who were vaccinated after the recommended age. So these are women who were vaccinated mostly in their late teens and a few in their 20s. And so you're seeing the gradual effect. The effectiveness of the vaccine is not as high as the age of vaccination increases. So, coming back, we can prevent greater than 90% of HPV cancers through vaccination. That's because the types of HPV in the vaccines that are being used now, they cause greater than 90% of all of the HPV cancers. The second common question that we commonly hear about HPV vaccination is it safe? And this is a big one, particularly for parents, but also for providers and for the general public. And so just briefly, we have many years of data and many different studies showing the safety of this vaccine. It is probably the most studied vaccine in history. because of concerns that are specific to HPV. It happens to be a sexually transmitted virus, and so it's received a lot more attention. It was also introduced at a time where we have social media, which was not in place for some of the older vaccines. However, this vaccine has been around since before 2006 in clinical trials, since the early 2000s. This vaccine is older than the first iPhone. This vaccine is older than your Google Maps and just so many things. So it is not a new vaccine. And we have many studies showing that it does not have any safety concerns other than what we usually see for common vaccines, such as the occasional severe allergic reaction. So as of a study published in 2018, so this is already quite outdated, there were 109 studies, over 2.5 million people in these studies, and in at least 6 countries. And all of those studies and all of the studies since this time have shown no serious side effects other than what's typical for all vaccines, such as those occasional allergic reactions and for teens, fainting. So given that, what are the recommendations for vaccination? And I mentioned that this is mostly for teenagers. So the American Cancer Society last July updated our guidelines similar to and in reaction to an update from the Advisory Committee on Immunization Practice, the ACIP. The recommendation is that girls and boys should get 2 doses of HPV vaccine, all girls, all boys, at the ages of 9 to 12. If children and young adults were not vaccinated on time, they should still get the HPV vaccine up to age 26. If the first dose was given after the age of 15, then 3 doses are recommended. But if the first dose was given before the age of 15, then only 2 doses are needed, even if the second dose is given late. The American Cancer Society does not recommend HPV vaccination after the age of 26. So a big difference with this update was that we recommend HPV vaccination for the ages 9 to 12. Others recommend routine recommendation of HPV vaccination at 11 to 12 or starting at age 9. So really, this is a simple change in wording. And let me explain why we did this. So we encourage healthcare providers, clinics, systems to start offering the HPV vaccine series at age 9 or 10. And the reason is not so much because it's more effective than at 11, 12. It is more effective than after age 15. But there's not a big difference, if any, in effectiveness between age 9, 10, 11, 12. However, a vaccine is only effective once it's put into the arm of a child. And we know that more kids go for well visits and go to the doctor at younger ages. So there's many more opportunities to vaccinate a 9 or 10-year-old than there are an 11 or 12-year-old. And we know that if we vaccinate more kids, which we will do if we start offering at 9 and 10, then we will prevent more cancers. So that's higher effectiveness for programmatic reasons. Now, there are many benefits of vaccinating at age 9 and 10. And let's look at it from the perspective of providers, systems, and public health. You initiate vaccination earlier. That gives you more time, more opportunities to give the first dose and to complete the series with the second dose. It also means that it's more likely that children will only need 2 doses instead of 3. It increases the likelihood of vaccinating prior to first exposure to HPV. Most of those exposures don't happen until the mid-teens, but occasionally and unfortunately they do. Not all sex is consensual, and some children do start experimenting with sex at a young age. So this covers our bases. It decreases the need to discuss sexual activity. The strong recommendation is not to talk about sex. We don't talk about the method of transmission of other vaccine preventable diseases. We don't say, hey, your child looks like they're likely to step on dirty needles, and so let's make sure that your child gets the tetanus shot. your child looks like they're at high risk of getting these other diseases that are caused by touching feces or going to Disney World. And so we don't need to talk about that for HPV either. Yet, many parents do bring it up, particularly parents of 12 and 13 and 14-year-olds. We have found through studies that if a child is sitting in a provider's office and the provider is recommending what vaccines they should get at that visit, if you have a 9 or 10-year-old patient with their parent in the doctor's office or in the health clinic, and the provider says your child is due for HPV vaccine today, which will prevent 6 types of cancer, the parent is very unlikely to say, hey, wait a minute, my child's not sexually active. It's just not happening. And so providers and studies have been saying that this is so much easier for us. We don't get into these long conversations that we really would rather not have. Another conversation that doesn't happen is the parent saying, I only want those vaccines that my child needs to go to school. So at age 11 and 12, the bundled messages, your child is due for vaccines that will prevent meningitis, HPV vaccines, and tetanus and whooping cough. Now, 2 of those vaccines are very often required for school, and HPV is not. Not because it's not as safe as the other vaccines, not because it's not as important as the other vaccines, but just because state school requirements vary from state to state and have different reasons for why they're required. And so by taking the HPV vaccine out of the picture, out of that 11 and 12 recommendation, then we avoid the parent walking out saying, I only got those vaccines that were required. My child is protected against Tdap and meninge, but not against HPV cancer. So we do have several studies that show that in large systems and small systems and in provider offices that vaccinating at 9 and 10 increases vaccination rates and is acceptable for both the systems and the providers. Now let's switch now to the perspective of the parent and the patient. Does a kid really want to sit in a room as their doctor and provider talk about their sexual activity? No, it decreases the need from their perspective as well. They also really like not having 3 or 4 vaccines for if we include flu, 5 vaccines if we include the COVID vaccine. They don't like getting all those vaccines in the same visit. It is safe, but it's not a preference. And so by giving HPV dose 1 at age 9 and HPV dose 2 at age 10, they come in at age 11 and yay, only 2 shots, Tdap and meninge, possibly flu, possibly COVID. So parents are very accepting of the recommendation at age 9 and 10. And are there any downsides? Nope. The only potential downside is if immunization wanes over time, the protection does not. It is very long lasting, probably will last indefinitely. So no reasons not to do this, lots of reasons to do this. A lot of parents say, well, if I miss the chance to get my child vaccinated at age 9 to 12, is it too late? No, it's not. Bring them in at 13, bring them in at 14. They'll get 2 doses. If you bring them in for the first dose at 15 or older, plenty of time to still get them vaccinated, but they will need 3 doses. And what about adults? Well, it has been recommended that by ACIP and by all of the provider recommendations that this vaccine should not be given routinely to anyone over the age of 26. However, there is a recommendation for informed decision making between a provider and a patient. So if a patient comes in and they're 29 or 33 or 44, it is okay to discuss this and decide whether they might benefit. But let me show you some of the data on effectiveness by age. And this is data out of Scotland. When the vaccine is given to 12 and 13-year-olds, this happens to be in girls in Scotland, and those girls come back for an HPV test for cervical screening in their early 20s. The effectiveness against advanced precancers is 86%. That's huge. Now it's even higher because this vaccine was the older version of the HPV vaccine that didn't include as many of the cancer-causing types. When those girls were vaccinated at age 17 and came in for screening in their 20s, the effectiveness of that vaccination would drop to 50%. And when they were vaccinated at ages 18 to 21, the effectiveness was only 15%. So if the effectiveness is that low when vaccination occurs at 18 to 21 and drops that dramatically with time, what do you think the effectiveness of this vaccine is for the average 35-year-old? And that's why the American Cancer Society really puts all of our focus on vaccinating on time. And if the vaccination on time didn't happen, then vaccinating in the teens or early 20s. And going back again to that Swedish study, there was 88% protection against invasive cervical cancer when vaccinated before age 17, and most of those vaccinations were on time. There were some that were vaccinated at the ages of 17 to 30, and there were about uh, eight eight times more cases of cancer when vaccinated at that age compared to the younger age. And so you can see the numbers of cases in unvaccinated, vaccinated on time, and vaccinated late. And again, I'll go back to this slide that I showed before with the green line is on-time vaccination and a cancer incidence of close to zero. And the blue line is later vaccination, mostly around the ages of 17 or 18. And you can see that while it's still beneficial, it's far less beneficial than on-time vaccination. So now I'm going to move on. We all know that over the last year with COVID, a lot of things in healthcare and elsewhere were disrupted. And there's been a big focus on getting adolescent vaccination back on track, as well as childhood and adult vaccination back on track from the disruption. This data shows before the pandemic that Tdap and meningococcal vaccine, those rates in teenagers were very high, close to 90% or even higher. But for HPV before the pandemic was just above 50%. We need to do something about this. This means children are going in, getting other vaccines, but leaving their appointment without being protected against HPV. Why is this? Why are they getting other vaccines but not HPV? We know that there are barriers at many different levels, parents, providers, systems. We also know that there are evidence-based interventions to do something about this, to address that. And the evidence-based interventions increase in their impact and effectiveness and number in systems compared to providers, compared to parents. So if you want to do something to increase the rates of HPV vaccination and cancer prevention, start with systems. Focus with systems, focus on providers. As for parents, they do hear a lot of scary stories about vaccination, and particularly about HPV vaccination on Facebook and through social media and in other places through their friends. Some of those parents just have a question or even a concern about vaccination or the HPV vaccine. This does not mean that they're going to refuse. This does not mean that they're anti-vax. And so what do we do when a parent asks a question? Well, first, we presume that they're okay, that they're going to accept the vaccine. We present HPV vaccination the same way we do with every other vaccine. Your child is due for this vaccine today. We'll give that vaccine at the end of this visit, and I'd be happy to answer any of your questions. You announce that we're giving this vaccine. You do not say, well, your child could get the HPV vaccine. Do you have any concerns about it that you'd like to talk about? If they bring you a question, answer the question. Please do not answer the questions that they do not ask. This takes a lot of time that we don't have, and it creates doubt where there probably wasn't any. If they have a question, answer that question. Okay, well, don't answer it with a ton of statistics. Don't answer it by judging them or dismissing their concerns. They are people who want what you want, which is a healthy, happy child. And so what do? Offer some empathy. It's hard to hear scary stories out on social media. Give them advice. They will normally almost always accept the recommendation and advice of their trusted provider and give them real stories. They hear about the stories, most of them not true, about the risks of vaccinating, but what they don't hear enough about is the risks of not vaccinating. Those 80% of people who over their lifetime will get HPV, those 36,000 people and growing of the number of people in the US who will get diagnosed with an HPV cancer, one of 6 cancers every year. So start with compassion, but not judgment. Use simple facts. Don't get into any long-winded, highly statistical explanation. Please don't restate the myth if possible, because restating a myth, even to say it's not true, just reinforces it. Share personal experience. Have you vaccinated your own children, your grandchildren? Do most of your patients get vaccinated? It is the norm. Well over half of people do vaccinate. Most parents, vaccinate for HPV. 99, 97, 98% of parents vaccinate against at least some, if not most, vaccines. The anti-vax movement is loud, but it is very small. Reinforce that vaccination is the norm in your clinic and in your practice or your office. And remember that it's not just what you say, but how you say it. So give a strong, effective recommendation. Now, coming back to COVID, we are down. We are down a lot of doses, over 1 million doses for HPV alone, just in the public sector. The public sector is about half of all vaccines given in this country, so that's probably over 2 million doses, about 20% down from before COVID. We need to do this, and we need to do something about it now. Over 70% of kids get vaccinated over the summer. It's the summer now. It's June. We have to vaccinate all the kids that we usually vaccinate every summer so that they can safely go back to school. And we need to vaccinate all those kids who missed their appointments last year. So this is a really important few months that we're coming into. We need to manage adolescent population health and get them all caught up so that they can have a safe return for school in August and September. We need to activate parents. One of those evidence-based interventions that I mentioned is the reminder recall. That's reminders to patients, and it's also evidence-based to have reminders for providers. Pull those overdue and newly due patient lists. Proactively reach out to all of your patients through your patient portals. Text messaging is pretty popular now, emails, phone calls, postcards. Get those parents in. Reduce missed opportunities. Yes, vaccinate at every well visit, but also vaccinate at any other visit. If they're coming in because they have a cold or because they had a cast removed, go ahead and vaccinate. If they're overdue, start recommending for 9 and 10-year-olds. Look at your data. So many providers and systems don't look at their data and think that they are vaccinating a much higher percentage of their patients than they actually are. Once you see the data, that's the first step in raising vaccination rates. Simply doing that and nothing else has been proven to increase vaccination rates of HPV and other vaccines. So here are the recommended evidence-based interventions for parents. I mentioned those reminders and just answering their questions and educating them. For providers and staff, remember, it's the team. It doesn't help if the provider strongly recommends a vaccine if the office staff at the front desk has expressed a negative opinion. Oh, I wouldn't get that one for my kids. And yes, that does happen. Professional education, standing orders is another big evidence-based intervention, and then access interventions, including reducing barriers, modifying the hours of service, including nurse-only visits, maybe after hours and on weekends, scheduling the second dose of HPV before they leave the office. That helps a lot. A lot of parents either don't realize they need a second dose or don't remember being told to schedule it. We have a lot of resources for you for getting back on track from COVID and also just in general. So we have playlists on the HPV Roundtable's YouTube channel. We have a resource library with hundreds and hundreds of resources from the roundtable, but also from all of you, from the AAP, the pediatrics, AAFP, from CDC. If you have a resource to share, you can send it to us. We will post it on the resource library. It's a one-stop for getting all of your resources. So to wrap up this talk, vaccine saves lives. HPV vaccine saves lives. It does not get easier than 2 shots to protect all kids from 6 types of cancer. We can only screen for cervical cancer. We can't screen for the other 5. And preventing cancers, including cervical precancers, is much better than finding them and treating them. Vaccination rates, particularly for HPV, are too low. We know that we can get them higher. We've seen it done for Tdap and meninge at the same age. And this will decrease cancer disparities as well as prevent cancer. We know parents value the HPV vaccine. We've asked them. There are a lot of providers who don't realize that parents value the HPV vaccine, and that's why they don't recommend it as strongly or in the same way as they do for other vaccines. But we have the data. We know parents want this vaccine, if only the providers will recommend it the same way they do everything else. And we know that we're all at risk, so let's protect our kids. So here's a call to action for you. Kids need to get caught up on all recommended vaccines so that they can safely return to school in a couple of months. Health systems and healthcare providers should identify families whose children have missed doses, contact them, and get them scheduled. Prompt clinicians when these children are seen to deliver vaccines for overdue and due vaccines. Don't miss any opportunities, and let families know what precautions are in place in your clinics and offices to protect them against COVID, because some are still obviously and for good reason concerned about this. Don't just tell them that precautions have been made, tell them which precautions have been made and make sure that they understand that they are safe. We all need to communicate directly to families about the importance of well child visits and about getting caught up with all of their recommended vaccines that were missed. Thank you very much for your attention, and I'd be happy to answer any questions that you have.